Good morning, everybody. Welcome. I'm thrilled to be here.
And I'm Rupert Walters. I'm the chair, and I also am thrilled to be here. It's wonderful to see this many people here. Thank you all of you. Thank you very much for coming.
So I'm Tanya Weiss. For those who don't know me, I'm the executive director of Cancer Support Team. And Rupert and I are very, very delighted to welcome you.
This luncheon is every year, and it's named for one of the two founders of Cancer Support Team, Gayle K. Lee. And that luncheon is 26 years old. This is the 26th time we've done it. And you may recall that she had a partner, a man running a radiologist, and they believed that you should handle cancer in a way that wasn't common then. They believed in treating a cancer patient holistically, recognizing his disease affects all aspects of life, physical as well as emotional and even financial.
Well, can everybody actually hear Rupert? Okay, yeah, I'm going to repeat what Rupert said because it's kind of interesting. The luncheon is named for Gayle K. Lee, and she was one of our two founders. And she and her partner, Dr. Arnold Wald, were really ahead of their time. They thought about treating cancer patients holistically. That meant not just physically, but their emotions, their finances, their relationships. And in the 70s, when we were founded, that was absolutely unheard of. And so today, since its founding, we've always been innovative in how we work and in the information and the resources that we bring to you here at this luncheon. And of course, today is no exception. Our guest speaker, Dr. Ani, I'm going to pronounce it, Anizi Ofodile, is the Chief Strategy Officer at Memorial Sloan Kettering, but his unofficial title is Futurist. I think we're all very interested in what he has to say regarding artificial intelligence and its use innovating cancer care.
Now, let's start by offering a message of hope. Ailish, our head of patient services, will come to offer that message of hope.
Speak into the mic.
Okay. Good afternoon, everyone. On this day, filled with both the pursuit of knowledge and the joy of companionship, we bless this food placed at our tables. We are grateful for all those gathered here, cancer survivors, families, friends, caregivers, and healthcare professionals. We remind ourselves that in numbers there is strength and courage, hope and caring, and someday for all, a cure. Amen.
And now, one of our bilingual nurses, Caridad Aponte, will say the same message in Spanish. Just as an aside, nearly 30% of the patients and families whom we work with are Hispanic.
Gracias. Buenos días. Estamos aquí hoy para ayudar a nuestros pacientes y gracias le doy. En ese sentido le digo, en este día lleno de la búsqueda del conocimiento y la alegría de conocimiento, bendecimos estos alimentos colocados en nuestras mesas. Agradecimos a todos los que estamos reunidos aquí, que incluyen y no limitado a los sobrevivientes de cáncer, a las familias de cáncer, a los amigos que tienen cáncer, los cuidados y los profesionales de la salud. Nos recordamos a nosotros mismos que en estos los números hay fuerza y coraje, esperamos y la ciudad y algún día para todos una cura. Gracias, Belén.
Gracias. Okay, everybody. So I want to say thank you to Ailish, thank you to Caridad, thank you to Rupert, and please enjoy lunch. And while you're eating, remember that this is a fundraiser. I would be fired if I didn't say these words.
Hardly.
So this is one of the ways you can help us continue to offer all of our programs at no cost. Let me underwrite that. We do not charge. We do not charge insurance. We do not use Medicare or Medicaid. Help us to continue to provide those wonderful programs at no cost. $25 is an easy spend, and those items are fantastic. So I am also going to say that once most of my staff have finished their salads, they're going to be coming around to your tables and making it really easy for you. Please be generous. Thank you so much. When it comes to discussing artificial intelligence, I have found there is a generational divide. Anyone here who actually uses ChatGPT or any other version of artificial intelligence on a regular basis, raise your hand. Oh, okay, it's better than I thought, but it's not even half the room. That gives you an idea. So, to be honest, I've been rather skeptical about using AI myself, and my younger staff have encouraged, let's say, pushed me to learn the benefits. And indeed, it is an excellent time-saving tool. However, I'm very concerned about it, taking over the human touch. I think that's something we can never lose. But in preparing for today, I did go to AI to learn more about our speaker. And here's what I found. Dr. Afodile joined MSK in 2023 as Chief Strategy Officer after serving as Executive Director for Clinical Transformation at MD Anderson. Among his many responsibilities is helping MSK steer a course into the future. I found an article that quotes Dr. Afodile about that topic. Quote, "There are multiple macro trends such as artificial intelligence, a focus on health equity, and adapting to climate change that are all converging in healthcare now. And the COVID pandemic pulled these trends forward by a decade." The article discussed how digital transformations have changed everything from how patients use telemedicine to how we can even receive some acute care at home. Yet, in the midst of these transitions, Dr. Afodile believes, quote, "making meaningful connections is an important value." Well, that's definitely something we at CST agree with and appreciate. A favorite quote of his that I found in this article is from a healthcare safety expert. Quote, "Change only happens at the speed of trust." That's a great place for me to stop and a wonderful place to ask Dr. Afodile to begin. So now, let's see. We may need to get this going.
Yeah.
Okay, I have technical assistance needs. Thank you. We will get your slides. Okay, thank you.
Pleasure.
Hi, Dr. Afodile, how are you? What's going on?
So thank you all for being here. It's an honor to be invited to.
You can bring it up. Don't lean it off, but you can bring it higher. Yeah.
So it's an honor to be here. So thank you so much, Tanya, for the very generous introduction. So as we load the slides, the way I thought about sort of framing today was just to tell a patient story. I think a lot of times AI, and there's a lot of hype, a lot of buzzwords, it tends to be abstract. So what we tried to do was just tell a patient story. It's a fictional patient. but it could be any patient, and just sort of weave in ways in which today AI is informing how we take care of this patient. And hopefully look forward to a Q&A and speak more about it. I think we're ready.
Yeah.
And you're good with the
Yeah.
right?
Yeah. And just real quick about myself, I'm a surgeon. I'm a plastic surgeon. As everything Tanya said was factual and correct, so to ChatGPT, everything, even those quotes are correct. That is my favorite quote. Actually, the full quote is, change only happens at the speed of trust. So it came from Peter Pronovost, who's a doctor at Hopkins. But then the full quote is, change only goes as far as people partake in that change. So just keep the full quote. So for today, I was going to just tell a patient story, fictional patient, and we just called her Simone. So Simone, she's 44, lives in Westchester, is a consultant who works from home, management consultant. Right? And unfortunately, as is becoming common, she's a young patient, no smoker, no obvious risk factors for cancer, no genetic, so BRCA, BRCA is a fairly common one, doesn't have that. But say in the story, over the last month and a half, she's been having a very dry, non-productive cough. Didn't think anything of it, season change, but it just didn't go, it kept on sort of persistent. So she went to her doctor, her primary care doctor, maybe a concierge doctor, and it's a little inside joke, this is real-time talk. And the doctor ordered a chest x-ray, which is the typical thing you should do. And in any other day, in any other era, the story ends there. Unremarkable chest x-ray, radiologists see multiple chest x-rays a day, and there was nothing that jumped out. But today, in a very AI-centered way, this one private practice radiologist had a program that sort of like has an algorithm to flag things that are a bit atypical. So it did flag a little small spot in the right upper lobe under 1 centimeter. Why that size? Because that's typically what gets people's attention, 1 centimeter nodule. So it was like 6 millimeters. But per the algorithm, which had seen thousands of x-rays, it said, you know what, look a little bit closer. So he flagged it to the radiologist, said, look, you know, that right upper lobe, take a look at that. And the radiologist did, and ordered a CAT scan. So ordered a CAT scan, and the CAT scan actually showed, you know what, there's actually something there, there's a there, but actually just given the features of it. You can use fancy words, I try to avoid fancy words in this talk, but like it's spiculated, you know, it's ground glass on the CT, which means that, okay, that is not, that's a concerning sign. So the radiologist then does more testing and then sends her to MSK. So that's the tee up. And what this story is going to sort of allow me surface is how AI is now engaging through diagnostics, right? Which I just talked through by having the algorithm say, you know what, on this x-ray, that right upper lobe has something there, let's investigate it further. You got the CT. That's how AI is now connecting to the story. And in fact, right now at MSK, we have our chair of radiology, is a gentleman named Larry Schwartz. He has built out an algorithm that from the CT can actually predict your stage, how your cancer is likely to evolve, what's the most likely response to the first-line therapy of said cancer, not for every cancer, just off the image, right? So now we are now being able to create what we call biomarkers just off of imaging. And that's like today at MSK. And it's in a research context. It's not paid for by any payer. It's not recognized by the FDA. But the field is moving so fast. And I want to pause here and say there's a lot of hype. There's a lot of hype. There's a lot of promise, a lot of potential. But because it's healthcare, probably say the only other field that has as much scrutiny is driverless cars. Because the stakes are so high, there's a lot of regulatory guardrails that we need to go through, FDA, Medicare, before it hits sort of like mass market or is widely available. But on a research basis, there's a lot that is happening. So in this story, going back to Simone, so the CT happens and we see that there is something there. So we do a biopsy. And one, I'll say, if there are two main things that's really pushing oncology forward, one is AI, hence why I'm here, but the one is precision oncology. So now, so at MSK, every solid tumor patient gets his or her gene sequenced, every patient. And to give you some context, in 1998, don't quote me, we did the Human Genome Project. It took 13 years, $2.7 billion. Today, that takes 5 hours and it's under $500, that entire process. And this is like fact. But one thing that I didn't appreciate until I got to MSK is just how much AI has actually made that process quicker, faster, cheaper, better. So even though it's not sort of like top of mind, but for genome sequencing, AI is driving a ton of what we're doing at MSK and labs everywhere. So, so she has a solid tumor. She gets a biopsy as is appropriate, and it comes out that she unfortunately has adenocarcinoma. And why I picked that is one sad statistic is in the United States, the rate of lung cancer in non-smokers is rising. And the most common cancer is adenocarcinoma, like this patient has. And 65% of those patients are women, actually. So there's this explosion of cancers in young patients or younger patients, relatively speaking, that we don't quite have a handle on. And unfortunately, Simone is that statistic. So that's her story, unfortunately. So she has adenocarcinoma. And because of next-gen sequencing of her tumor, using AI, we're now able to say, you know what, this tumor has a driver mutation. So cancer is a disease of mutations that are unchecked. And unfortunately for her, there's a mutation, EGFR, which is a real one, that is driving her cancer. And then she comes into MSK. So long-winded story, but this is a fairly typical, not sci-fi, could happen today, right now. And so she comes to MSK, and I'll say, so it's funny, I use ChatGPT a lot for my medical care, actually. I think it's quite incredible. Fortunately, knock wood, for now I have not a ton of chronic conditions, but every so often I'm like, what's the spot? I take a picture, upload ChatGPT, and I get things that are actually like quite accurate, actually. But I think the reality is ChatGPT should not substitute medical advice. That's not what it's intended for. It's also not validated or cross-checked. There's a lot of hallucinations, which we'll talk about. But I do think personally, and I think literature supports this, it has empowered patients from a knowledge standpoint in a way that was not the case 5 years ago, 10 years ago. So in this case, Simone says, I have a lung cancer, adenocarcinoma, what does it mean? And she gets a litany of information. But now she comes to the clinic visit with one of our physicians, empowered, and has a more nuanced conversation. And we may debunk some falsehoods that you saw on ChatGPT. We may reassure. But certainly the conversation is much richer intellectually through AI. Now, one thing we're doing in MSK, and I'm sort of reflecting to Tanya's comment about sort of the emotional relationship in healthcare. So we are launching under our hospital president basically an automated scribe. So right now, doctors are really pressed for time. And what we're doing now is we are allowing the doctor have a face-to-face eye-level conversation, no distraction. I'm not like typing on my laptop. I'm just like meeting someone in a very vulnerable time in her life and trying to build a relationship and understand where they're coming from. And what we're doing now at MSK is we are now having automated scribes transcribe the entire encounter. So I'm focused on the patient. I'm not thinking about documenting. And that we are rolling out right now at MSK. So we're really excited. Others are as well, but it's really, really exciting. So that happens. And from that encounter, we make a plan. And I think the one thing that AI is doing is really getting this idea of precision oncology at scale. So now we know her mutation. Two things happen. One, we are now able to match her with her mutation to available therapy. So we can say, look, you have this mutation, there's this drug available today against this mutation. So that's why that's important is targeted therapy is typically oral, not chemotherapy, less disruptive, less complications, and more survival benefit. So that's one. Number two is we're also able to match her to a clinical trial, just offer information in a medical record. So in an encounter, hypothetically, we could say, you know what, Simone, for this mutation, EGFR, there's a trial happening right now at MSK for a new drug by Regeneron or anyone else that can address your mutation. So the doctor's having to think about what trials are open. AI just surfaces it in the medical record, in the typical workflow, unobtrusively. That's happening today as well. So we've also launched that at MSK. And most cancers are solid cancers. Most solid cancers require surgery. So it's going to get surgery. But now the bulk of our thoracic surgery at MSK is about 85% robotic. So we now use the robot to do most of our procedures for lung cancer. And using AI, it's called computer vision, we're actually now able, with the robot, to really see how much tissue we need to take out to make sure that we take out only the tissue we need, not an inch more, not an inch less, because that does get to margin, gets to cure. So that's happening right now as well. And last but not least, after her surgery, we are also able now to do a vaccine that is personalized to your tumor. So we typically give it's an mRNA vaccine. So mRNA, in the way we think about it, is for prevention. COVID is obviously how it's sort of got into public consciousness. But we're now using the mRNA after surgery in the adjuvant setting for cure. So we found that if you're able to create a vaccine targeting specific proteins that only exist in the cancer, not your body, using AI, because it's very, very computational. You have to say the tumor makes, actually, in the millions of proteins, which proteins will elicit an immune response. That's a computational activity using AI. We're able to pick the right protein to make a vaccine to give to Simone after surgery to allow her immune system sort of like recognize the tumor as it's trying to come back. So that's happening today as well at MSK on a trial basis. So in this one story, you've seen how AI helped upstream with diagnosis, right? From the X-ray to the CT scan to the ChatGPT giving her information to have an informed conversation, to the patient access. We even now are thinking about using AI to streamline our scheduling, to sort of predict on the OR what day makes sense, what surgeon. So we're using AI in the back office operations in a meaningful way, all the way to after treatment. MSK, like other health systems, are really thoughtfully trying to bake in AI throughout the entire journey. Now take a step back and say, it's a very boring topic, it's called governance. The reality is, I think all organizations have a responsibility to have responsible AI use, right? So the first thing is, what's the governance infrastructure to monitor algorithms? Are they working as you intended to do? When you create these algorithms based on data, to train the data, is it the right mix of patients from age, from race, from gender? So all these comes under governance, and I'll say at MSK we've done a lot of work to have the right governance framework in place for AI deployment at scale. And even when you launch an algorithm, you have to monitor the algorithm over time. So some algorithms function well, sometimes they don't. So that's also a governance exercise. So that's the journey we're on as an organization. And to situate this at a macro level, I like that word. So 2 million people in the United States every year, plus minus, are diagnosed with cancer. That number is going up. 1 in 2 men, 1 in 3 women in their lifetime will get a cancer diagnosis. So think about that. So 40% of Americans will get cancer, and that's a fact. And the thing is, cancer is not the same in every patient. So a breast cancer, a lung cancer, across 4 people of the same gender, even from the same family, it behaves differently. So you sort of have to use data to make the right call on how you treat this. And when you look at the slide, it's a busy slide, but on the first column, think about that as a specific perspective, a clinical perspective, an imaging perspective. They all tell one side of the story. And what we're able to do now is link these perspectives to tell a holistic story and now allow us to take care of the patient the best. And that takes a lot of work. that involves AI. You have to clean the data. You have to link the data together. You have to make it stable and secure. And a lot of times, the data, the relationships are not particularly obvious. They're nonlinear, and that's an ideal task for AI. So that's sort of where we are now. I'll say the journey we're on is to take all this information and derive personalized, meaningful insights, in this case for Simone. Like, that's all we want to do. One stat that I love to say is, in the last 5 years, 90% of cancer data has been generated. So think about that for a second. That just, the thing to take away is just the volume of data, and the speed of data generation is just immense. So no physician can keep up to date with all that's coming. It's just not possible. So that's one strong case for AI, is helping us, nurses, physical therapists, physicians, surgeons, all of us, sort of make sense of the data, but take that data at scale and make the right decision personalized to the patient in front of us, right? And for MSK, our charge is to not just be sort of standard of care, but to be state of the art, right? So our charge at MSK is to define the next wave of innovations. And one of my colleagues likes to say, tomorrow's care today. That's our charge, right? And I think that speaks to our culture, speaks to our people right there on that table. It speaks to our team, speaks to the science, but it's also a data exercise. And I think AI certainly helps us. So every year, you have about 9,000 patients come through our world. Think about all the learnings we can gain from those patient journeys for the next patient that comes, right? So that's an AI exercise. So this is sort of my second to last slide. Is our charge is to say, for Simone, how do we give her the care she needs today that is in the context of her life? So how do we use AI to minimize work disruptions, get her back to her kids, get her back to her hobbies, minimize complications, only take out the amount of tissue that we need. So for lung cancer, it's a big deal, right? If you take out more tissue than you need oxygen for longer, can go up steps quite quickly. So these things are deeply impactful for the patients who have the privilege of serving. So certainly AI helps us with that. And certainly in her case, being able to give her a personalized vaccine, which we're doing today on a trial at MSK, is incredibly exciting. So this is our mission. We only exist for one thing, to end cancer for life. And it's a privilege that me and the team are able to support our patients on that journey. We recognize that cancer will touch everyone directly or indirectly. So it's something that we take very seriously, and happy for the audience and look forward to the questions. Thank you so much. Yes.
So let's start on this side of the room. Are there questions over here? Yes, and would you please repeat her question because we are recording?
Absolutely.
Thank you.
MSK is a diagnostic and treatment, I think, institution. I want to know how you relate to the development of AI. Do you have AI researchers on site, or are you related to another institution that is specifically developing the AI that would be useful for your doctors?
Great question. So the question was, MSK is a diagnostic and a treatment facility. Is that what you said? And that is true. And the question was, how are we using AI? So let me expand on the first portion. We are also a massive research center. So Memorial Sloan Kettering is the marriage of Memorial Hospital and the Sloan Kettering Research Institute. So we actually have a massive research enterprise. We have the most government funding for cancer in the country, actually comes to MSK. We have a number of leading scientists who focus on just AI. So the scenario I said of Dr. Schwartz, which is true, he's our chair of radiology, he has a grant from the government that uses AI to predict treatment response, staging. So that's happening today. So the answer is yes. I do research involving AI myself personally with my lab. I have a lab. We do AI. So the answer is we have a lot of people focused on this work. However, The reality is AI is capital intensive. It's very expensive to do AI. Cloud compute, the NVIDIA chips cost a lot of money. And also with humility, we recognize that the field is moving so fast. So it's impossible for any one entity to sort of be at the bleeding edge in a self-sufficient manner. So we do partner. So earlier this year, about February, we partnered with Amazon enterprise-wide to support our AI ambitions across drug discovery, research, and back office operations. There are other relationships with philanthropy and grants that people pursue, but at the org level, we've aligned with AWS and Amazon on that. And there are other relationships with tech companies beyond AWS that we're also prosecuting right now. So short answer is both. We do a lot on our own, so homegrown, but recognize that the field is moving just way too fast. So we've partnered with technology companies as well. Great question.
I'm going to jump in and ask one that's very on my mind. How often I hear you can't trust what you're getting from AI because it makes things up.
True, hallucination, yeah.
Well, how do you know what's a hallucination and what is actually real and a real treatment? Or how do you handle that aspect?
Yeah. And I also double down and say the hallucinations are also very plausible sounding. It sounds like good advice. So the first thing is, in that scenario, you validate with a trusted physician you have a relationship with. So that's why I put that in there. And I'll say also that, and don't want to get too technical, but there are also technical fixes for hallucinations. So for instance, you can have two LLMs. It's called adversarial learning. So like go against each other. So you could have one LLM say, okay, I have adenocarcinoma. What does it mean? And you could cross-validate with another LLM and see what's consistent across both of those. But by and large, I think the key thing that you should take away, one of the things is it's not intended to substitute, right? So you should still engage with a treating, credible physician who's a cancer expert you have a relationship with. That's real care. I do think recognizing, and this may be a bit controversial, so I'll say in healthcare, there's always been a massive knowledge gap historically that I personally have just never quite supported, actually. I think what's happening now is there's a ton of information that's leveling that gap. It's good and bad, but I think it's net positive that people have more knowledge on their fingertips. The question is, how do you get insights from them? And that's when engaging with your physician to take away, okay, what's really relevant to your situation, what's factual, not hallucination. I think that's where the doctor-patient relationship comes in. But I think I personally, and this is not speaking on behalf of my employer, but I personally think it's actually a good thing that information is now readily available for the first time in a really long time to patients. I'm net supportive of that, actually.
Okay, do we have any questions on this side of the room? Oh, quite a few. Okay. Patty.
Are you able to go back in time to prior patients' records, especially those patients who may have that kind of cancer represent again in a different way, and utilizing all of the past research that was done at the time of the diagnosis, assist that patient also with further treatment, or are you just limited to people starting in 2025?
Great question. So when it was Patty? So Patty asks the excellent question is, are we just limited to patients of today, or are we able to go back and sort of curate and look back on past patients with a similar presentation to Simone and see what lessons we can draw from them? Answer is yes. So the reason why I went back to the slide is that so at MSK, we have a really impressive database in oncology. So you see digitized medical records of over 500,000 patients. So that's on the slide. That's why I showed it. So we've archived the data of patients that we treat. So this is where it gets expensive. So you don't have to just archive it, which is like one point in time. You have to maintain it. So patient comes back 2 years later or has a scan for surveillance and it's negative. You have to update the data set with all this new information. In fact, let me just go back even more. So focus on the middle column. Make that data updated in real time, right? Make it secure, so no hacking. That's a problem. We don't want that. But also make it readable and usable and useful, right? And if you go to the other slide, then on the last column, how do you surface this data in real time so the next Simone that's in front of me, I'm able to access all that knowledge like that, right? That's the role of AI, actually. So fancy words like APIs and Tableau, these are visualization tools where in a patient encounter, we're able to surface the insights or the lessons from prior patients like Simone, right, to inform the patient in front of me. So how do you take N, all the patients, to solve N plus 1? That's an AI journey.
Okay, at the front table, yes. Go ahead.
Hi. I have a question in regards to, you said that for FDA, it's very difficult, with healthcare to get certain things approved. So it's a two-part question. If you guys are doing scans or any kind of work at MSK on current patients using AI,
Yeah.
how does that factor into insurance companies and HIPAA and all those things in the background? Are the insurance companies rejecting like a certain diagnosis that maybe wouldn't have been picked up in the past? And is that something that MSK kind of has to keep up with and have a relationship with the insurance companies to make sure that patients are being covered for the care that maybe wouldn't have been covered?
So the question was, keep me honest, is great question, first of all. It's all great questions. The question was, in a world where the regulatory environment has not caught up to AI, which is true, how do places like MSK that's using AI sort of like do it knowing that there's no reimbursement from payers, knowing that there's privacy concerns, right? So I think that's the question. So let me try and unpack that. So as of today, and I'll say the current administration is pretty bullish on AI, actually. So I think the feeling is that a lot of regulation will come down in this administration than in the last two, which included Trump as well. But just because of where the puck is moving, the current people in leadership are just particularly focused on this topic. So something's going to come. Number two is, for lack of a better word, if the regulatory scrutiny becomes heightened once it leaves the hospital environment. So I'll give an example. So let's say a patient, I'm using an algorithm at MSK, and I want to share that algorithm to a doctor in White Plains Hospital. That's a problem. But to use it within the MSK environment, under a research protocol, totally fine, above board. The third part, which you get to, is the truth. These algorithms are not reimbursed at all by any payer. So it's a long story, but for something to be recognized by a payer, Medicare or Medicaid, it has to get on the fee schedule. And there's a certain level of evidence to allow something to get on the fee schedule. And I think the reality is for AI, it's unclear how to generate that evidence. So let's say in this scenario, Larry Schwartz's algorithm, which is true, which is happening right now, can predict that her response to an EGFR target therapy will be better or worse. I think from the payer standpoint, unless it drives outcomes which require a randomized trial, they're not going to pay for it. So that is cost that we bear in service of mission, delivering the best care for our patients. And that gets to the privacy question you asked, which is, so long as it's not leaving our environment, there's no privacy concern because it's a sandbox. It's the MSK, HIPAA compliant, sort of like data platform. So I think the regulatory scrutiny is when it leaves a particular environment. And then the privacy concerns, they do exist, but it's no different AI or non-AI, which is like cybersecurity. It's all the same thing. It's all within MSK tent, so to speak.
Okay, this side of the room. Anybody over here that I'm missing? Yes.
I have a question about false positives.
Yes.
Since in your example with Simone, you're going to look more deeply at a possible tumor than you would have without that AI.
Yeah.
So what's the level of false positives, and how quickly does the learning of the model overcome that concern with false positives?
Great question. So the question was, what's the sensitivity of the algorithm? So just So she said false positive. So sensitivity means the ability of a test to detect a true positive when it's there. What you don't want is a test to call out a false negative, which is bad, which means the tumor there, it missed it, or for a test to say that is the tumor when there's nothing there. So think about the anxiety, the further testing that comes with that. So I'll say that's a really hot topic as relates to liquid biopsies, actually, for the most part. On this scenario, in fact, I'm glad you asked that question. I deliberately put it in this scenario because for algorithms, so when you publish an algorithm in like a journal, you sort of have to show 4 things. Not to get too math specific, but you have to show the sensitivity, the specificity, the positive predictive value, negative predictive value, and ultimately the area under the curve. And so most algorithms go through that vetting in the first place before it's like widely adopted. So that's the first question, the first thing. The second thing is, in this scenario in particular, the next step was a non-invasive test. It was a CT scan, right? Now, it costs money, yes, covered by insurance, but it's not like I'm asking for a biopsy, the next step. So I think the scrutiny for sensitivity or specificity is if that next step involves a procedure, like a biopsy, or like a surgery. That's when the bar is higher. So the first is an X-ray, which, as an aside, X-rays are very imprecise. It's like a 100-year-old technology. It's very imprecise anyway. That's why the next step was a CT scan in this story. But great question.
Other questions? Please raise your hand. Yes.
In your example, you mentioned that when you had an understanding of what the tumor was, you looked at the proteins that it generated.
Yes.
You said something like it generates millions.
Yes.
And then you could use an algorithm to come up with ones that were probably going to be responsive to things. Could you just expand on that?
Yeah.
Where does the data come from, and how does that happen?
Ooh, okay, so I like to know when I'm at my limits of the science. So I may project like I know it, but let me try. So about 2.5 years ago, a surgeon, his name is Vinod Balachandran, did some really exciting work whereby he recognized that for some tumors, pancreatic cancer in particular, people just live long. So pancreatic cancer is a terrible cancer, has a 5-year survival rate of about 15%. But because we're MSK, we have this huge volume of data. He could look back and say, you know what, these patients live longer than the typical patient. Back to your prompt, Patty, about data sets. So then he went back to those patients, and so at MSK, we have something called a biobank. So we actually take tissue specimens from most patients we treat and store it. So he said, okay, for those 20 patients who lived 10 years, let's get their tissue. So he did that, and the thing he saw was for these patients, they just tended to just attract the immune system. For some reason, something about them just made the body's immune system recognize and fight it. So then he was like, it's kind of interesting. So then he worked with a computational researcher, an AI researcher, to now say, okay, what was it that the body was reacting to 5-10 years later after the surgery? And what it was is it's called neoantigens. So basically, most tumors make proteins, neoantigen proteins, that are unique to the tumor that are not otherwise found in the body. Like tons of them, actually. But the issue is, of those, let's say, 100 neoantigens, probably 2 or 3 or 4 elicit an immune response. So now, if you're going to create a vaccine, typically around one of those proteins, you have to guess correct. And I think it's also worth saying, actually, take a step back. I think AI is nothing more than a probability machine. It's not deterministic. It's probabilistic. So it says most likely. So when you go on ChatGPT and you say, okay, what is cancer? All it's doing is sourcing the entire internet and guessing the most likely response to that question. That's all it is. It's actually not anything more than that. So for tasks that involve large volume of data, AI, or tasks that involve making a bet, then AI is uniquely suited to that over an individual human being. So for those neoantigens, of those 100, his name is Ben Greenbaum, the computational scientist. He was able to say, these two, you should probably make a vaccine around these two, because he's betting that those two will be the ones that will elicit an immune response in these patients. So that's what they did. So it's about, I think, 20-ish patients. And then they made a neoantigen vaccine for them, it's pancreatic cancer. And now we're doing it in other cancers, including colorectal cancer, actually. And for those patients that we made the vaccine, some did not respond, which means they guessed wrong, actually. But for those that responded, they are now seeing incredible long-term results. So that's the power of AI, is that prediction function.
So we're going to take 3 more questions. One is Nancy.
So this is sort of built on, I think, Tanya's earlier question. I know you said, that it's a tool and it's not to be just, accepted on paper. But it's not always just a mistake, at least we, from what we read, there are things being put out there in the universe that are actually not true, not scientific. And money is being cut from real scientific data. So how are you, at some point, do you feel like this will sort of muddy the waters on using AI for this purpose or in this way?
That's a great question. It's almost a philosophical question. Is that fair to say? I think more than anything else. So I think that.
Please repeat the question.
Oh, sorry. So the question is, thank you. The question is that we're in an era of false information, just sort of going out there unchecked. And how do you reconcile that, since AI is trained with this data, against the backdrop that real science, which I'll get to in a second, is being underfunded, right, or is under threat from a funding standpoint. So how do you sort of balance those two things? So I say the first thing I'll say is that, and honestly, an AI talk could last a whole day. So at MSK, so science has a long arc. So there's something called foundational science, which is just like basic science. Then there's something called translational science, which is sort of like getting into patients, having like human models for questions. There's something called clinical science. There's something called population health science. So it's sort of like 4 main buckets. AI cuts across all of those. So I think we're in a world where it's hard to uncouple science from AI. Now, it's case dependent, but I think I'll say by and large, across foundational, basic science, translational, clinical, population. So I do more pop health science. Everyone's using AI. So I think, this idea of there's science independent of AI is increasingly no longer the case. That's number one. I think to the philosophical question, I think it'd be a philosophical question, which is sort of like, what do you do in a world where, for lack of a better word, information is cheap, but insights are rare? That's a tough one, I think. And I think the way I think of it is, back to Simone, I think we need to evolve back to a world, or course correct back to a world where people who spend time dedicate to learning a craft like science, whether it's a PhD, a nurse, a physical therapist, a surgeon, a medical oncologist, their insights are recognized, valued, and rewarded, right? Now, I think, so, to be honest, I also admit that for a long time, we've not done a great job of communicating our insights, to be honest with you. I think that's the gap that, Joe Rogan fills, right? And I think there's a value in communicating well to people that we've not done the best job at, right? So we do great at, podiums, at conferences, but engaging people, meeting them where they are knowledge-wise, we've not done the best job at. I think the other thing that I will also somewhat controversially say is we've also not done a great job, scientists, of being humble to acknowledge when the evidence base is shifting. So the thing about science that I love about science, actually, it's not deterministic. It updates itself all the time. So, 10 years ago, sort of target therapy was just like totally the bleeding edge. We thought that was it. And then more things came that has like really forced us to reckon with our prior knowledge. I don't think physicians, scientists do a great job of acknowledging when the goalposts have moved. I think that's something we should be honest about. So science, by definition, is evergreen, right? So I think, it's a philosophical question, philosophical answer. I would say that more work needs to be done on everyone's part to really sort of solve for this, because in a world where the cost of knowledge, of information is only going less, look at the human genome, right? It now costs under $1,000, what 20 years ago cost 2.7 billion. So think about that, like degradation cost curve. And it's only going to keep on getting lower and lower. In a world where information is going to be ubiquitous, insights is only going to rise in importance. So how do we curate, preserve, support, maintain insights? That's the question.
One more question over here.
Hi. Tanya introduced you as a futurist, so I have a futurist question for you.
Oh boy.
You can pick whatever it is and whatever time frame it is. A year from now, 2 years from now, what is something that's coming down the pipe that you're really, really excited about that AI world that's going to help treat cancer patients?
Yeah.
And you can say, a year from now I'll be able to do this, 2 years, whatever it is, but I'd love to hear what you're really excited about.
Can I give you two?
Whatever you want.
So the reason I'm going to give you two is the question is, as MSK's futurist, what's the one thing I'm really excited about in cancer? I took it to mean any part of cancer, diagnosis, treatment, related to AI that I'm really excited about. One, I think people have tried to put a time horizon and failed. So this is no time horizon, but I think it's going to come. So I'm really excited about two things. One is, and they're related actually. So one is liquid biopsies. I think, so right now, if you have cancer, the things we have good screening paradigms for are prostate, breast, colon, lung, and cervical cancer, right? Most of them involve some procedure, colonoscopy, prostate biopsy, colposcopy, very invasive, very uncomfortable, very disruptive, very expensive. So I'm really excited about liquid biopsy. So what it is a test, a blood draw, that is not necessarily new, but the science is just improving so fast. It's a blood draw that what I hope we'll get to is being able to tell you at the earliest stage that you have cancer. And not just that, you have X cancer. So it can tell you you have a cancer, but where is it is an open question. But where I would love for you to go is, X person has gastric cancer from a blood test. That's where the field is moving. And related to this is using the same technology, you can now get treatment, a Whipple procedure, and we can now, from a blood test, survey you. You come to a doctor every year or every 6 months and pick up those same cancer proteins before it shows up on a CT scan. So that's called minimal residual disease, MRD testing. So this idea that from a blood test, you can upstream detect cancer at the earliest possible stage. Because the most cost-effective treatment for cancer is at the earliest stage. Best outcomes, less morbidity, is the cheapest, is the least disruptive. And on the back end, after treatment, you can detect recurrence well before a CT scan shows anything. That technology exists today. It's on a trial basis in the UK, in the US as well. And people are, I think, somewhat frivolously overstating what it can do today. But it's a matter of time. And using AI, you are now able to have the sensitivity, specificity of these tests get to where we would need them to be comfortable, to have it paid for. That I think is a game changer. Imagine just like every year get a lab test, and have the peace of mind that is negative. I think that's transformational. So that's my answer. Thank you.
How about that? I found that information